Thank you all again for joining. And I think what we'll do is we'll get started. The chat box is open, so do introduce yourself because it's really nice. It's always very strange doing webinars online and not knowing who else is in the room with you. So I'd be really grateful if you just say hello to each other in the chat box. And then there is a Q&A box so that we will be taking questions in the Q&A. But again, with this webinar, we did ask people to put in questions directly. And so we have quite a lot of questions, but we will look at the themes of the questions that go into the Q&A during the webinar and see what we can do to answer those. Thank you to all our sponsors. Without this, we couldn't do it. And we move on to the next slide, please. Brilliant. So I've talked about the chat and I've talked about the Q&A. Obviously, we do record the webinar and it'll be on our website within the next 24 hours. And we will obviously send you a link to it too. So please do share with other people as well that haven't been able to attend today. Closed caption has been enabled for anyone that needs to use it. And please, there's other information on that slide, but I'm not going to go into it because I want to get into the actual webinar. So our speakers today, who will have a chance to introduce them, Charles, and thank you so much, first of all, to all our speakers, because without you, we couldn't do such great events during our Patient Partnership Week. You can see there, we have Charles from Caribbean and African Health Network. Vanessa, thank you so much for coming and telling us your personal experiences. Anna Whelan from the National Centre for Rural Healthcare, Project Support for the Rose Regeneration. Yasmin, thank you so much for coming from the Anthony Nolan. And Sarah, our Head of Patient Partnership and Involvement here at the Patients Association. Before I hand over to our speakers, I would just like to run a very quick poll just to give our panelists some information on what you have to say. So if we could launch the first poll question, I'd be really grateful. Okay, so there you go. Time to get you busy interacting with us. So we're looking forward to hopefully you can all see the poll. And it would be great. Oh, it's moving fast. Okay. So where are we at with the poll? So I think maybe to get started, because I think most people have managed to do it. What were the results of that poll? Okay, so we're pretty even across financial barriers and communication barriers, with geographical, cultural, and system barriers coming in after that. That's quite interesting because it shows that we have a really good panel here and that our spread of what we want to talk about today is great. So time for me to come to some questions and let you introduce yourselves. So Charles, I'm going to come to you first to introduce yourself and to just give us a little bit of background over a couple of minutes.
Thanks, Rachel. Good morning, colleagues. Great to be with you all. So I'm Charles Kwaku-Odoi, Chief Exec for the Caribbean and African Health Network. And we are a national organization. Our real focus is the Black Caribbean African community. And our mission, since we were set up 8 years ago, has been on eradicating health inequalities for our community within a generation. But I think this subject is really important to me because I have a couple of hats on. I'm a nominated governor at Manchester Foundation Trust in Manchester, but also I have been a patient and public voice partner, for the NHS HIV clinical reference group, and also in the last 18 months been a PPV for, the national Quality and Governance Group. So really delighted to be here and to see you all. Thank you.
Brilliant. Thank you, Charles. And Vanessa, I'm going to come to you now. And will you introduce yourself to the audience?
Sorry, I didn't realize I was mute.
Always happens.
Okay, hi. So I'm Vanessa. I'm a patient living with sickle cell anemia, HBSS, which is one of the severe versions of the condition. I was diagnosed at birth, but even up to this day, I can get the question, when did you discover you had the condition and stuff, which highlights the lack of education about the condition within the system. And yes, over the years, I've experienced various challenges with trying to maintain good health with this condition.
Brilliant. Vanessa, thank you so much for coming, because I know sometimes, you know, it's so important to the Patient Association that we really have lived experience on the panel, and Sarah will be talking a little bit about the work that we've done and some stuff that we highlighted. And of course, myself and Charles last week were at a launch of a report by the Race Observatory around sickle cell and investment in sickle cell that's so badly needed. So going to hand over now to Anna. I think, Anna, you've a couple of slides you want to share with us as part of your introduction.
I do indeed, if you wouldn't mind putting them up on the screen. Thank you. Yes, I'm Anna Whelan. I work for Rose Regeneration, which is an economic development agency based in Lincolnshire. And one of the things we do is we manage the National Centre for Rural Health and Care. And I was really pleased to be invited along here because ensuring equity in rural health and care is our mission. And it's very challenging. I was interested, geographical access didn't come up very high in that poll we did just now, because it is a huge issue if you live in a rural, coastal or remote area. We know that rural communities have an older age profile and more people with multiple health issues. We all know someone who's retired, you know, to the seaside of the country. But of course, those people can live there for quite a long time now. And we know there is also a very strong connection between health needs and other social, environmental and economic issues. The obvious one, of course, being transport, which can be quite challenging, especially if you're not well and perhaps you can't drive anymore. Many health boards are going over to digital access, which is fine unless you're digitally excluded, as many older people are. So there is a connection between all these things. We know many rural and coastal areas have very high seasonal peaks in demand. I'm sitting here in Orkney, which is a group of islands off the north of Scotland. We can have 3 cruise ships in sometimes in the summer in one day, and with thousands of extra people in the system who aren't catered for. You know, they're not in the stats. Then rural health and care providers struggle to recruit. They often rely on temporary staff, and rural health teams are smaller, so you've got limited opportunities for training and development. And all of these things mean that rural healthcare is more expensive to deliver than if you're in an urban centre. Should we move on? Should we move on to the next slide? There we are. Yes, the National Centre, we set that up in 2018, and its mission is to reduce health inequalities in rural areas. And we focus around 4 key themes. I won't go into these here in detail now because we've got really limited time, but they're data, to make sure that we all know what the challenge is, because many policymakers are not aware of this fact at all. Research, looking into what works in rural areas. Technology, we mentioned that before with digital access. Workforce and learning, making rural a location of choice for healthcare workers. And in 2020, we published our Rural Proofing for Health Toolkit. And this is because it's all very well saying that health providers must do rural proofing. And it's now in legislation that they must, but it's how to do it is the tricky bit. And this helps talk providers through the questions they need to ask themselves. It's very much like equality impact assessment, but thinking of peripherality being on the edge as an equality issue. And you see the last one of those is workforce, which since 2020 has emerged as a massive issue worldwide. And so we're focusing now on a new toolkit, which will just be about workforce. But if we look a bit further now into the next slide as to what rural proofing can help us to do. Well, by asking that question, how will your plan or your strategy affect people living in rural or coastal areas? You can improve the outcomes. Just asking the question is sometimes enough. You can demonstrate a commitment to act equitably towards rural communities and all the people who live there. You can support place-based approaches. That's very important because that is really the key to providing services in any far-flung area. You can design out any unintended gaps or unintended consequences in your service provision. And you can identify opportunities to innovate and make better use of the resources available to you. And it doesn't always have to cost a lot of money. And finally, you can embed that good practice within your organizational service. So like equality impact assessment, it just becomes second nature to always think, how is this going to affect the people who live a bit further out? And that, I think, is me done. Thank you very much.
Thank you so much, Anna. And Yasmin, going to come to you to introduce yourself. And I think you've said this morning you've a couple of slides you'd like to share as well.
That's right. Thank you so much. So hi everyone, my name is Yasmin Sheikh. I work at Anthony Nolan, which is a cell therapy charity, and I'm going to explain what that is in a little bit. So hopefully this will work. I'm just going to share my slide. Can you see my slides okay?
Yeah.
Great. So I'm going to be talking about the world in which I work, which is stem cell transplant and cell therapy. And just in case you're not aware, Anthony Nolan, which is a charity founded in 1974 as the world's first unrelated stem cell donor register, supports to match people who need a stem cell transplant with a donor who's willing to donate their cells. So really incredible people willing to help a stranger in need. So that's one of the main things that we do at Anthony Nolan, but we also do more than that. So we support patients with information, we provide patient grants and practical advice, we advocate on their behalf, and we do research into cell therapies. So cell therapy is quite a specialist service. So having a stem cell transplant or a gene therapy or another kind of advanced cell therapy is a really complex process, and patients need to undergo very intensive chemotherapy. It's what we call conditioning to prepare them to receive the donor cells or their own cells in some cases. And so that means they have to spend a lot of time in isolation because they effectively have no immune system. And then there's a long recovery process. So most patients are not able to work for that period of time and during that recovery. And if the patient is a young person or has a carer, usually their parents or carers are also having to take time out of work. And we've estimated that there are about 30 in-person appointments required in that first year alone after transplant, and it can be as much as 1 to 2 times a week after discharge from hospital in the first 6 months. And there are only a limited number of specialist transplant centers in the country. And so from the data we have at Anthony Nolan, we estimate the average distance for a patient one way is 55 miles. So really what Anna was saying resonates with our patients as well. And that distance can be a lot bigger because sometimes patients have quite a specific reason for transplant and only 1 or 2 centers can deliver that. So they might have to travel even further. And we know that this then causes quite a lot of hardship in patients and families. So most of the grants that we give out are because of travel costs. And because our patients are very immunocompromised and they can't really go on public transport safely, they have to spend money on private travel like taxis or petrol for the cars or parking as well. So we did a survey last year, and 40% of the patients and family members we spoke to said that they not received enough support from existing government and NHS schemes. 38% of patients said that they had been unable to even pay their energy bills, which is really worrying because when you've had a transplant and you're at home recovering, you need to have a safe and warm place and be able to cook nutritious food in order to allow that recovery to go as well as possible. And 41% said that they'd been considering going back to work earlier than they had been advised to by their medical teams. Again, really worrying given just how intense the process has been. And so we also asked if patients had heard about the existing travel cost schemes that the NHS does offer. So there are two schemes. One is called the Non-Emergency Patient Transport Scheme, and another is called the Healthcare Travel Cost Scheme. And most people had not heard of either of those schemes. And even when they had, in the comments, they told us that usually those schemes were not appropriate for their needs because often it was a shared ambulance service with other patients, or they had to wait for many hours not knowing when it would come to collect them. And when you're going through this kind of intensive treatment, that's just not appropriate for your needs. In the healthcare travel cost scheme specifically, you have to claim that back after you've incurred the expenses, and that hits people who don't have the funds to pay for it in the first place the hardest. So at Anthony Nolan, we've been trying to advocate for an improvement. So we are calling for a patient travel fund, so a dedicated pot of money to help people travel and with these costs that they have to incur and they don't have a choice. We are also calling for more what's called ambulatory services. So those are services that are a little bit friendlier, either closer to the patient's homes where possible, or outside of the hospital setting where carers and family members can come along and safely stay with the patient while they're in that recovery phase. And we're also calling for reform of those travel schemes I mentioned to make them work better for patients. Thank you. Stop sharing
Brilliant.
now.
Thank you so much, Vanessa. Yasmin, sorry. And something that we're really interested in too, and I'm sure everyone on the panel, this low income travel scheme and how it is communicated and when it was last reviewed is another issue for me. And then I'm going to come to Sarah to introduce herself, and then we're going to get into some more questions.
Hi everyone, I am Sarah, Head of Partnerships and Involvement at the Patients Association. And here in our charity, our whole ethos is around patient partnerships. So we ensure that patients are really getting involved in all aspects of our work. And we do think it's important to understand that every person engages differently. So we really need to ensure that we're adapting the ways that we do patient engagement and co-production approaches. And, you know, we've got a long way to go and we're always learning. And we did do some work recently with Weber Shandwick around a model called CORE, which stands for Community, Offer, Respect and Ease. And that was aiming to address key barriers to accessibility and inclusivity in health communication campaigns. And I just think the impact of inequity is huge, and social determinants of health, so that's, you know, housing, access to healthy food or ability to work, can have a big impact on patients' health outcomes. So I just think that's really important to consider. And when we're talking about partnership, it's also talking about working across sectors. I think it's really important that we can all learn from other sectors and work together, whether that's pharmaceutical industry, government, charity, education, or NHS. And we recently did a piece of work where we created some toolkits and animations to ensure that people have as much information as possible to know that there's financial support out there and what people can do to be prepared for appointments. So I'll leave it there, but I'm sure we can continue the conversation some more.
Absolutely. Thank you, Sarah. Thank you all for joining us. So now I think it's really getting into the questions, because we have a lot to talk about here. We know, and you've just all really outlined how the health inequalities and the wider social and structural determinants of health can have a profound impact on patient experience and health outcomes. And Charles, I'm going to come to you first. And I just want to, if you could cover the significant barriers that you see through the work that you do.
Yeah, thanks, Rachel. I think, some of the challenges we have as a community is the very reason why CAHN was set up. So there's a big thing around lack of trust. And I think sometimes we don't talk about that so much because it feels intangible, but it weaves in and does impact on, how people access services. So the typical example I always use is during the pandemic and the vaccination rollout. Many did not understand why the Black Caribbean and African communities, as well as the South Asian community, weren't going to have the vaccine. And it was partly due to some of the historic things, the lack of engagement, the lack of belonging, and those variety of issues all did feed into. And sometimes when we've even managed to convince people to get into, healthcare, they end up having poor experience, and then the outcomes, adversely impacted as well. And unfortunately, people feel they're not listened to the way they're spoken to. And we know very well there are issues around language as well, and the cultural nuances. And so for example, some of the mental health conditions for some people who are not born in the UK, they don't understand that terminology around depression, anxiety, and all that. But there are also structural issues. And so for us as an organization, we welcome the inquiry by the Secretary of State for Health into maternity. 2025, why should Black women be nearly four times more likely to die during childbirth? It's a structural issue. So there are a plethora of things, but I think the lack of trust is really, really important. And our colleague Anna, who spoke about, coastal or rural areas, if I'm right, talked about data. I think we need to improve how data is collected. And sometimes we do invest in the infrastructure for the data, collection, but not in the communication and how we engage with patients about their information. And I know people get shocked when I say this, but when the NHS app was launched, for example, there were people in our community who were sending messages to friends saying, if you're going to download the app, then please delete me from your contacts, because of the lack of trust. So whilst, we all in favor of the three shifts, we want things to come into the community, we want to focus on prevention. And as colleague mentioned, others have mentioned it, one size doesn't fit all, analog to digital. We need to make sure we're looking at the different levels of layers when it comes to communities and the historic stuff and ongoing challenges in order to improve assess or dismantle some of those barriers and structures. Thank you.
No, absolutely, Charles. And I'm gonna stay with you for a second, because I think the trust and data issue overlap quite a bit, don't they? Because I think yesterday as well, in the long-term health plan, we had an announcement around AI looking at safety issues. And my issue with that was, you've got to bring communities and people with you on this. They've got to trust it. So you and I last week met again in Blackpool, at the launch of the Weathers are talking around health inequalities, and he talked about giving people a he wants a microphone, he wants patient voice to be there, and I genuinely believe he does. If there's a big trust issue, how do we allow patients to be real, true partners in their care from your community and the work that you do?
Yeah, thanks, Rachel. Unless we resolve the trust issue, it will be virtually impossible to carry, patients along. And a practical example, if we look at, patient complaints, I mean, like I mentioned, I'm a governor. We want to know what patients are saying about their acute trust. What are we then doing? What is the learning that can be triangulated across other areas? When we look at complaints, there are low levels from ethnic minority communities, because sometimes people have been made to feel you should be grateful for the care you get in here. If you were, in a developing country, you're going to have something about 200% less or whatever it is. So all these things are really important. So we need to really work on the trust. We need to find a way and get trusted voices to lead that charge, where we wanting patients to feel that sense of belonging and really speak into the microphone that our Secretary of State and the government wants to provide. But also the other challenge, and 3 years ago, some of us were highlighting this around AI and some of the challenges around ethnicity, code. So there will be some real issues there, because probably 5-10 years ago there was lots of evidence out there that when people from ethnic minority background went for interviews, sometimes because their names could not be mentioned properly, it even disfavored them. And now it's all about the coding and the back end related stuff. So we've got to really, really, hone in on the trust issue if we want people to come along on the journey. Else, we're going to have a new wonderful 10-year plan. We're going to be talking about the 3 shifts, but there will be cohorts of our community that will be left behind. And unfortunately, those are the ones that will, be a burden on the system, unfortunately, because they have been left behind. They've not been carried along. Once again, when we as an organization were promoting the vaccine, there were people who said, oh, you've been asked to come and talk to us now because government wants to reopen the economy and lockdown is not good for business. That is the only reason you've been asked to come and speak to us. So the trust is massive. And as we think through the 3 shifts and with some of the concerning announcements over the weekend about patient voice and how it feels quite fragmented and quite complex, I think we've got to be careful that one size doesn't fit all. So I'll leave it there.
No, I think you're absolutely right. And one of the things I learned very early in my time at the Patient Association was how we had to continually, I described it as looking out the window to the team, making sure that we were getting to new voices all the time rather than relying on the same voices, so that we could continually kind of build and expand the trust in the Patient Association to represent the voices. And you alluded there, I'm going to come to Vanessa now, so I'm just going to let you know, you just alluded there to the news at the weekend of the closure of Health Watch, which obviously is extremely concerning to us too, and they're great colleagues of us, and we were in touch with them yesterday. But it's dismantling a patient voice before we see what's coming to take what are the plans. So obviously very interesting what the long-term plan will say on that. Vanessa, I saw you agreeing quite strongly Charles there. I was like, I have to get you in now. So Vanessa.
Yes, because both as a patient representative and a patient advocate, someone who's done stuff like peer reviews and has tried to be on patient panels across my hospital and hospitals that are within what they call the HCC branch, that's within the East London area. I've had a chance to see both firsthand and via other patients' experience some of these serious issues that are happening, and trust is a big flag for why patients feel afraid to come forward anymore. I'll give you an example. They did a meeting not long ago, and they were going, "Oh yeah, we're getting less complaints and stuff. So I guess that means things are good." And the response was, "No, patients are just afraid or scared or fed up. That's the reason you're not getting the complaints anymore, because when they've done it in the past, it either you just get like a fake story with no actual outcome, or they claim they're going to investigate it, but because you're as a patient, you can't avoid that system, that process anyway. So when you go back in, you become a target, and then that makes you then fearful and afraid, and sometimes patients will even stop attending because of the problems that they encounter. And then the third part is that you just get fed up. You've been trying to you've tried to voice the issues. You've tried to say, what can we do to fix it? And nothing is happening. And you're still having to fight that battle. So of course it gets frustrating, it gets overwhelming. And then if you're dealing with the condition where you're already in and out of hospital and having a lot of treatments anyway, the time and energy it takes just to focus on that and your recovery process is so much that at the end of the day, you just feel like you don't have the energy to focus on those things that you feel aren't going to go anywhere anyway. So those are some of the major issues that are resulting in there being like no progress and patients not wanting to even try to voice their concerns anymore. So that's why I was agreeing quite strongly with what Charles was saying there. And it's interesting from the polls that they put up. For me personally, all those points are valid points. For each patient, it will vary at the ratio, which one is number one and which one comes in last place, but they all have a factor at some point or stage in your life or care plan. Because, for example, finance is an issue. As a person with sickle cell, when I was trying to work, I have to go to the hospital, let's say. So for like my exchange transfusion, I'm doing that every 6 weeks. So that's what, a month and a half. So I have at least about 8 appointments a year for that, plus 8 appointments for the prep for that. And then I've got, let's say, about roughly 5 consultants, different consultants that I need to see, all those appointments within the year. All of that adds up. And then if you're trying to work, it's a hidden disability. I look healthier than I feel. So when I'm talking to my employers, it's not always they're necessarily trusting or believing what I'm saying, because they're like, well, you got your arms, you got your legs, you're standing. So what's the issue, kind of thing. And a lot of patients have that challenge of, how do I prove and I'm able to justify that I need this to then be able to be functioning well to do my job. And if I am having to take holidays to cover the medical, where's the time for them when I need the rest to be okay to present myself to work? And it's that vicious cycle which then impacts the finances. And then if you've got children, add in the burden of childcare. Do we have the time to even attend these appointments and look after the kids? Is there someone to cover the childcare whilst you're down for what? It may be 1 day, 1 week, one month. It adds up. So, and then the next challenge is stuff like housing. Am I even housed in an appropriate housing for my situation? Even me and my siblings, there was one point where we were housing in inappropriate housing, and then it was back a while, like a few decades back, where the ambulances, they could refuse to carry you down. I don't know what the criteria was at the time. So it's like, I'm having a severe crisis. I can't walk. You're telling me you can't safely get me down because I've been housed inappropriately. And you're saying it's a health and safety for you. So how do I get to the hospital in a safe and caring manner or whatever? And these are the kinds of things that patients will then be experiencing over and over and over. And then it gets to you, which then leads to another issue of mental health. I am no longer able to cope with this because I've hit my limit. I've hit that brick wall. What do I do now? And the problem then is, can I even access the psychological support I might need to be able to then deal with all of these factors and have a safe place to just go, this is what is going wrong, help me, kind of thing. And from my personal experience, the hospital I'm with, there was a point where they tried to get in a psychologist. The psychologist was there for a few months to a year. Then they left. There was no replacements, and there was that big void and then the patients are like, well, what do we do? Because you're saying I need this service, but this service isn't actually available. So there are loads of challenges out there, and it can be very distressing trying to navigate the best way. And sometimes this is where communication becomes an issue, because knowing where to go, who to ask, how to get that right information. And sometimes patients just don't even have the time, the energy, or that safe communication bubble to be able to say, this is what I need. What do I do? Where do I go to be able to get that? So yeah, sorry, I kind of rambled about those.
No, you didn't. That was all absolutely what we wanted to hear. And I think Vanessa, what what I got from you there, I think that whole thing around communication and care navigation, but also around the need to really understand what matters to you in terms of you as a whole person and what you need. And I think we're going to hear this from Anna as well in terms of rural. but that energy is power. And I think that's what myself and Charles were trying to get across as well, is if your life is so busy and you have so much going on and you're trying to work and you have children, you're trying to live and you're trying to do all these things, do you have the energy to be that active kind of patient power, that microphone, that megaphone that we're hearing about? And that's what we need to try and get to, is that you are allowed the space and the time, and that we really work to try and make sure that we get to a voice like yours, Vanessa, all the time.
Yeah.
And I think that's really important. Yasmin, I'm going to come to you now, because Vanessa talked very much there about kind of that financial struggles, and we're hearing this a lot through a lot of the work that we do. And I think I don't know where I got this stat, but I think it's one of your stats. 71% of patients struggle with travel costs. We know definitely from piece of work that we did a while ago that people often will choose between appointments and actually just living that week, having food, everything else. What do you think could immediately put in place by the government to ensure that we make it, that patients don't have those economic barriers to getting to the appointment they need to get to?
Thanks, Rachel. And yeah, that's a really timely question given what's been going on with the government's plans to change access to welfare. So a lot of you may have been following the news. So there's been a bit of a rebellion amongst the MPs with the planned cuts to personal independence payment and changes to who can access support due to having a disability or a health need. So for me, the obvious kind of big question that the government needs to ask itself is whether or not they are prepared to support people who genuinely need help at some of the most vulnerable times in their life. And every person that I have spoken to who has been diagnosed with a condition that needs a stem cell transplant wants to get back to work. They want to get back to their normal life eventually, but they physically can't during that period of time. And at the moment, people spend so much of their time and energy just fighting the system as it stands. And the changes that the government had been intending to bring in, we fear will only make that worse. So making it harder to prove that you need to access help. Having to jump through more hoops to continually kind of do the paperwork and report back in and prove that you're trying to get back to work, when really you should be concentrating on getting well and putting those things in place that will actually enable you to safely return back into society if you're able to. So in answer to your question, Rachel, I think generally kind of looking critically at those changes to PIP, and hopefully the rebels, from my point of view, will win the day. There's a debate in Parliament this afternoon, I believe. But then on a more practical level, the things that are available right now, such as the non-emergency patient transport scheme, the NHS healthcare travel cost scheme, again, those are not fit for purpose. And we really feel that the government, at the very least, should review how they are working and how they are being accessed, and take a view into really simplifying that process.
Absolutely. And I think we would all agree on the call on that. Anna, you've heard quite a lot now from the rest of our panel here today. What are your reflections on what you've heard here, and then the impact that that would have on rural and coastal areas?
I think really, I mean, particularly what Charles was saying about one size doesn't fit all, that really, really resonates in rural areas. We have so many cases where we need bespoke solutions. I was consulting, doing a community engagement exercise around the islands last year, and a couple of examples people raised showed just how much you do need an individual solution. For example, Grampian sends up to Orkney every year a mobile breast cancer screening unit. And people were saying that the team running that are really brilliant because they send out invitations, and before they do that, they check the ferry timetable to make sure that everybody can get to their appointment at the right time. And they said, why can't everybody do that? You know, it'd make life so much easier. And just one other example, which I think you'll like, is I went to Grahamsey, which is an island of about 20 people. And they said when someone needs an injection, the nurse comes out from the Stromness surgery on the boat. Now, the boat only calls in at Grahamsey for about 5 minutes on its way to Hoy. So the patient has to be waiting on the pier. The nurse jumps off the boat, gives the injection, jumps back on the boat again, and then carries on to Hoy to do her surgery there. So that just shows you how bespoke our solutions have to be.
Yeah, no, that's amazing. And I think that kind of fits what everyone here, I think, believes in, which is we've got to look at how do we go and work with people and understand what people need. Charles talking about the vaccination. I think mostly the reason the vaccination numbers were higher was because communities work together through WhatsApps and everything else, not because we did a policy statement at a national level. Sarah, just quickly coming to you. So Charles, you've covered the first of the shifts, which is analog to digital, and the need for trust in data and trust in data, and actually working with people in partnership very early on as we're gathering data so that we can understand and have no biases within our AI is something important to me. I'm going to come to you, Sarah, around from sickness to prevention. So and you've led on a couple of really big pieces of work for us around social determinants of health. What are the critical changes, briefly, needed to ensure the most vulnerable of us are not left behind?
Well, Vanessa said something that really stood out, which was patients need to prove themselves, which I just think is just such a worrying thing to think about. And I think it's so important. So we really, really need to start just listening to people in the first instance. And I think prevention will only properly work if it's equitable by design. You know, I think a lot is rooted in tackling the broader conditions that cause ill health. So really focusing on social determinants of health first. So as Vanessa again said, you know, treating housing, thinking about education, poverty, not as individual areas, but how everything can work together and think about everything holistically. So we did some work with British Red Cross, and it did show us that, you know, those that are a bit more vulnerable or marginalised groups are getting left behind. So we found that people, if they're living in shared accommodation, it means that they're not having their private health phone calls, or people living in rural areas, Anna, as you were saying, can't travel to their appointments. People with addiction are being stigmatized, or, you know, asylum seekers who are living in hotels and not knowing where to go to help. I could talk about this all day, so I'll just try and make a few very, very quick points. I think we just need more culturally competent services. I think everything is so much about trust, which we keep talking about, and also about data. You can only work with the data that you have. So if minoritized groups are not getting seen in data, then they're going to be excluded from any initiatives that are taking place. And also in terms of data, thinking about digital, we need to make sure that digital means that are, you know, speedily taking place aren't making people get left behind.
Brilliant. So we have another poll question, and I think I'm just going to launch this poll question and then come back to the panel for a conversation. So the poll question is around, from your perspective, how would you rate meaningful patient engagement with marginalised communities in your experience of healthcare? So we've got a minute in which to do this. Okay, there's our minute. Good to see some excellent and good, but that equating to do my maths now, 18%, but 70%, we can close that down, find it fair and poor with 12%. So not great, not good at all, really. So I think we have a question there. So Charles, how can we do it differently and better? Like, obviously, much, much better.
I think there has to be some humility that we need to first and foremost understand people. And when we talked about person-centered approach, it has to be, what are the things going on for people, and deprivation could be one, but also culture, language. I mean, we've had several times people sent appointments in English when English is not their first language. And I think the point earlier on that was made around travel, we see that with people who need to go for chemotherapy that, don't qualify for, any public funds due to, their immigration status. So we need to be really mindful of what, the challenges, ongoing challenges that, different parts of our communities are dealing with. I think, our data collection, but also working with patients to really understand why we're collecting the data and how that helps inform, co-designing of services and the delivery of services is really, really important. And, rather than shouting and rejoicing when we don't have complaints, I think the point is being made. It's maybe because people feel I'm not really important. Nobody would really hear me, rather than we doing something really brilliant. So I think we need to reset, the way we've done things, and really put, patient in the heart of what we do. And then also we need to get our health system to a place where, in this day and age of information overload, and yes, we know there's misinformation, there are some who do their own research before they go and see the GP or before they go and see the consultant. And it's about listening to what people have to say, because with the best will, and yes, people have done their training, they're duly qualified, you cannot feel what the patient feels. You don't really know what they're going through, and they may be the best to really explain things to you. And I think active listening finally is really important, because sometimes the result of the misdiagnosis is not because patients were not talking about the symptoms and how they're feeling, but they've been even judged before, they explain exactly what they're going through. And I think those things are really, really important.
Thank you. Vanessa, I was always coming to you next, because once again, I can see you going, yes, 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 yes. So...
Again, agreeing with Charles on that one. I've even had personal experience where I've walked around with like specific pains and issues for, actually it's happened twice. One time it was like 1.5 years before I could really get them to listen to me, and then they were confirmed, oh yeah, you've got this, by the way. And then it's just like, wait, what? Are you serious? A lot of the times patients are feeling very frustrated because they're not being heard on any level. It's like, whether it's a new registrar that thinks he knows everything, so he's already switched off, or it's a consultant that thinks they know you better than you know yourself, kind of thing. There's always that situation. Don't get me wrong, there's some amazing people out there, some amazing nurses and doctors that are just so intuitive and actually listen. They don't just listen, they hear you, and they're actually responding and acknowledging and trying to work with you to find the solution. But unfortunately, there are just too many of the ones that are like, no, no, no. And they're like talking over you, or they've dismissed you, or they're halfway out the door before you've even finished trying to explain what your problem or situation is. And it's so disheartening and it's so frustrating, especially if that story needs to come. It doesn't come until like years later after that problem. and that the barrier to get over that problem has already occurred and left you with whatever injury or mistreatment and stuff. So I think that's a very, very big area that needs to improve to help facilitate making that whole process much better.
Anna, I'm going to come to you because I think, you know, how do you think patient voices from rural and community areas can be better heard? Better heard. Somebody in the chat there, somebody in the, it said one of the Q&As was just saying that in radiography, many areas are now trialing and utilising travelling X-ray ultrasound so that people can travel less, missing less work, and also being more familiar. But that's really good. So that's obviously a really good sign of listening to what rural and coastal communities need. What other ways do you think we can listen to patients, that the system should be listening to patients, hearing patients, sorry?
You've got to go to where the patients are. And a good example of that is coming from Powys in Wales, which of course is a farming community. Now, farmers are notoriously difficult to engage with or to get in for preventative health services. They're always far too busy. It's lambing or it's harvest or it's something else, you know, and they leave things till the last minute. And we do know that mental health in particular is a huge issue in farming communities. So what Powys has been doing, they've got an initiative called Farming Fit. And this is a three-way partnership between the council, their health board, and their third sector, their community voluntary organisations. And what they've been doing is they've been going around visiting livestock markets, which of course is where the farmers are, and setting up a walk-in sort of consultation. So, and it's really working because farmers go, you know, for a cup of tea, and there's this little team sitting there saying, come and talk to us, you know, can we do anything to help? And they've had a terrific reach. So the program's been extended and then extended again, and it's doing really well. So that's just an example of how imaginative you can be in finding solutions that work in rural areas.
Brilliant, thank you, Anna. And Yasmin, tell me, what's Auntie Nolan think? How can we reach those voices better and really listen, like Vanessa said?
Yeah, I totally agree with what all the panel members have said so far. And what Vanessa was saying really resonated with me, because I feel that often the health system adopts this kind of medical model of what it feels is important and prioritizes, which is totally fair enough. But we also have to remember that people are humans and they want to know, what's this going to be like in terms of my social life? What's it going to mean for my quality of life long term? And these are all things that I don't think our healthcare professionals at the moment are necessarily supported to approach and have conversations about. And if they do, then it's more of a kind of intuitive thing rather than something that they've had support and training on. So an example that comes to mind is we had been advocating along with the Sickle Cell Society and others for access to this new gene therapy for sickle cell and thalassemia. So it's a potential cure for those conditions for people who don't have access to a stem cell transplant donor. So a really important new therapy. But as Charles was saying, there are a lot of issues around trust, particularly when it comes to this kind of genetic therapy in the communities who would most benefit from access to that. And what we've been hearing is that although people do want to hear from the doctors and nurses about what that medical journey is like, they also want to speak to other people with sickle or thalassemia who have been through that process themselves and that they can connect with on a peer level. So it's about allowing people to have those networks and connections and supporting that, but not having that kind of paternalistic relationship and enabling people to make decisions that suit them and their lives.
Brilliant, thank you very much. And we're coming to the end of our webinar, and I think we could have spent another hour. There's so many more things I want to talk about, but Vanessa, I'm going to come to you for the last word here, and I'm just going to first of all give you a couple of lines on what I think I've heard about what we need to do as a health and care system. So, and I think it builds on some of the questions in the chat, in the Q&A around data, and is start with people, start with patients before we do anything in designing and delivering any type of service. We first need to say to patients, actually, what is it you want and need, and how can we work it together? So that is your designing with. And then when you're in your individual consultation, Vanessa, you talk strongly about the need for really good shared decision making, really working, and Charles, you did too, about really understanding what matters to that person and understanding what's happening in their whole lives. And Anna, I think everyone really spoke about that. I think that we have to have a level of humility. And I've been talking about this within my team for a long time, that I wanted the Patient Association to be seen as a, you know, very humble organization there to make sure that we're representing the voices that we're hearing. And we need, when we're working with data, we need to start with people. We need to make sure that data doesn't create more inequalities, but actually decreases inequalities. Trust, really understanding why, maybe, you know, historically, why now, what's happening in the system, what's happening in the world at the moment, that maybe we don't trust the healthcare system as much, and people may not trust it as much as we would like them to. So to understand that barrier and really work to get around that barrier. And I said start with people and patients, and now I'm saying, and then when we do it, we end with patients and make sure that we really think, how has this reached the most vulnerable in our society? Because if we get it right there, we're getting it right for everyone else. And I think that's really important. Vanessa, what have I missed?
I don't think you've necessarily missed anything. I think that there are going to be challenges, because for communities where they've already had bad experiences, when you're setting up like a meeting or an inquiry, whatever, if the people that are coming in aren't aware of what the historical issues have been, there's no progress being made within those within those sessions, because a lot of the times patients are like, well, we've done this before. Are they even going to actually hear us and do what they promise? For example, we've had previous sessions where, like, we've tried to bring back ambulatory care within our hospitals. We did everything we were told to do. We wrote letters to the execs, we set up meetings, we did the campaign and whatever. We outlined what we needed, why we needed it. And then they created this panel that was supposed to help progress things, and it just died over the course of time, because, and it was predominantly the, sorry, it was so it's predominantly the people that we were waiting on would be setting up the meetings, canceling the meetings, rescheduling, and it went nowhere, and it just fizzled out. So then the patient's like, well, you told us to do this, we did it. And we got to a point where nothing happened. So of course, everyone was frustrated and then just gave up, kind of thing. So it's like, if you're going to do something, you need to be able to not just say, this is the session we're having. You need to do like a comeback session to say, okay, we tried to hear you. This is what we tried to do. Did it work? Where did we go wrong? What can we do better for next time? And so on and so forth. I think that is lacking a lot of the time, to help people understand, okay, at least they tried, and at least they came back and told us what the problems are, so we know what we can do better for next time, kind of thing. I think that at least appeases, if you're not able to be successful in the follow through of what you're trying to promise.
Yeah, that's hugely important, that we, you know, work together and feedback where things may not be possible at this moment in time, and what we might be able to do together in the future. Thank you all so much. We're getting some lovely feedback in the chat. Really, I think some really good solutions there. Solutions I know that we all think people know, but it's something that we'll definitely be pushing on behalf of all of you. I hope you're all going to come back in a year's time and we can have a chat about maybe where the long-term health plan, 10-year health plan, has got us to in terms of more equitable access across all the structural and social barriers that we've identified and discussed here today. To the audience, thank you so much for coming. It's been really great to have you. We have a few more sessions, and I think the slides are moving slowly. So this afternoon, this afternoon we're looking at digital innovation with heart. And then tomorrow we have a conversation with Jim Mackey. So Jim Mackey, Chief Executive of NHS England, and some of these questions will be coming to him, and I'm sure that you've heard some of the stuff that he has talked about going back to basics and getting to patients and working with patients. And then Thursday and Friday we have a couple more, so feel free to sign up for those. The link is on our website. And then we have another slide which tells you a little bit about our membership. We have a free membership, so please do feel free to sign up. But also, if any of these issues have affected you, we do have a national free phone helpline that you can ring for more information and guidance, and that'll come up on the next slide. So it just leaves me to say thank you so much, and I'm really sorry that we're 3 minutes late finishing, but thank you.